Good evening, everybody. Welcome to the MPhen lecture for, this is the second one for January, isn't it? This is the second MPhen lecture in January. Our lecturer tonight is Jenna McLaren. Jenna, you've changed jobs recently, so I'm just going to let you introduce yourself and your subject, okay? And obviously we'll have a break at some point halfway through just to give us a chance to get up and stretch and what have you. But off you go, Jenna.
Thank you for that nice welcoming. My name's Jenna. I am currently a mixed role at the moment. I'm senior nurse in emergency and acute medicine, and I'm on a secondment for that at the moment, but my substantive post is clinical educator for emergency and acute medicine. So don't ask me when I'm going back into my substantive post, because that still has a big question over it at the moment. So tonight I'm going to be covering risk assessments, but we're going more into the risk management. Given the audience that we're talking with tonight, we're going more into management rather than the basics of risk assessment. So have I got the ability to share my screen? I do.
Let me check.
I
always forget to do that. This is really bad.
That's
you have
right.
now.
Thank you. So can everyone see my screen?
Yep.
Yes, that looks lovely.
Lovely. All right, so we'll get started. I'll skip this one because I've already done the introduction, but we'll go into webinar information. So tonight's session is obviously being recorded for all those that have missed the live session and gives them a chance to catch up. If you have any concerns about being recorded, just let us know now so we can stop and reevaluate. Can you guys keep yourselves on mute just for the time being, just so there's no background noise? If you do wish to speak, Jeanette is going to keep an eye on the chat function, but otherwise I'm really happy to take questions throughout and whatnot. So just, pop your space bar on and chat throughout. I'll make sure I try to answer all your questions tonight, if not follow up. If you've got any problems with reception, sometimes it does help to turn your video off, just better reception that way. If you finish the session, make sure you complete your feedback form so you can get a certificate and claim it on your CPD. And then obviously, please don't share the codes for the MPhen sessions or APhen sessions unless they're for fellow Phen members. Okay, without further ado, let's get moving. So tonight's objectives, we're going to outline the laws surrounding risk assessments. We're going to look at defining a risk assessment, review the 5 steps of a risk assessment, and obviously, like I said, tonight's session, we're going more into the risk management rather than the basics of a risk assessment. We're going to understand the difference between operational and strategic risks, understand risk scoring, and define the importance of monitoring and reviewing of risks. So let's go on to the really dry section of risk assessments and talk about the legality. So obviously there is a selection or a multitude of acts, regulations, policies, procedures that relate to risk management throughout our workplaces. So it doesn't just have to be obviously here in health, but obviously any place that you work, there's a lot of acts surrounding the health and safety. I'm not going to go through a lot of the acts and regulations tonight because that's probably a 2-hour presentation in itself. So the main one that I'm going to touch on tonight is obviously the Health and Safety Act of 1974, and that's the primary piece of legislation that covers obviously occupational health and safety throughout the entire UK. And obviously, as that piece of legislation basically outlines that as an employer, we have a duty of care towards our employees and the public and everyone that passes through our workplace. And then obviously to make sure that our employees understand that they have a duty of care for themselves and obviously to other people. So everyone that's working in this workplace needs to make sure they have the knowledge and understanding and the skills to be able to identify risks and have an understanding of what they need to do to follow up on those risks, and to be able to identify and, you know, be able to control them. So if we go into risk assessment. Now, the next couple of slides, I'm just going to be doing a bit more of a recap about risk assessments and the basics surrounding it, and then we're going to go on to risk management. So when we're talking about risk assessments, we're talking about essentially a collective term for an overall process that involves risk identification, risk analysis, and risk evaluation. And that process is conducted, you know, relatively systematically. And if we think about it, the overall term is that we want to avoid an unwanted outcome. Now, what causes that unwanted outcome? You know, and we use the terms hazards and risks. So a hazard is obviously anything that might cause harm, damage, or loss. But then the risk is that there is a chance that suffering or harm can be caused by that hazard. But it's not just about, you know, a particular thing affecting a person. It might be the possibility that will affect a workplace, not being able to achieve objectives and whatnot. So risk assessments are really important because obviously everywhere that you work, regardless of the department, it's essential that obviously we are risk assessing on an ongoing basis. And it's to make sure that we're identifying both operational and strategic risks. And I'm going to go into those terms a little bit more in depth in a little while. So I guess what we need to remember that in risk assessments in healthcare, what sets us apart from, you know, performing a risk assessment in possibly, you know, hospitality or anywhere else, is that actually the difference is that lives can be at stake with us in healthcare. And that sounds like quite a dramatic term, but it is the truth. You know, we have patients, we care for them, and they put their lives in our hands. So we need to make sure that everything that we're doing is risk assessed appropriately, and that that's an ongoing process. And obviously, when we want to risk assess, we want to make sure that we're doing this in a timely manner, that we're doing it accurately and efficiently. Because, like I said, this is the difference between life and death for some people. In terms of risks, there can be more than one potential, and risks can be uncertain. So we know that if there was, you know, a hole in the path or whatnot, we know that that hole causes a risk to people. And we know that there is a chance that if somebody falls in that hole or trips over, that they might end up with a hip injury, or they might graze their knee or hit their face, or worse. But actually, unless somebody does fall in that hole, the outcome of that risk is uncertain. And what we want to be thinking about is being proactive and making sure that we reduce the chance of somebody falling in that hole. But if somebody has already tripped over, then actually that risk becomes no longer uncertain, and it actually becomes something that needs to be managed. It's an issue because something has already happened. So with a risk assessment, there are a couple of things. Obviously, this is a structured approach to ensure that all hazards are identified. And a risk assessment should identify those that might be affected by the risk. And when we talk about those that might be affected by the risk, we're talking about not just people. So we're not just talking about patients, staff, you know, visitors that are coming into the hospital or contractors, but we're also talking about you know, things like finance, and also the reputation of not only the department, but the overall health board or the trust that you're working in. We need to make sure that we're considering all the risks to people and ensure that all of our processes and policies that we're following to make sure that we're meeting those health and safety requirements. And that goes back to what we were talking about, all those regulations, all those acts that are relative to us in the department, and making sure that we are meeting those, because those are statutory. We need to make sure that when we're doing a risk assessment, that there is a certain level of detail to make sure that we can understand its potential harm and an accurate risk rating, and making sure that all those elements can be achieved. We need to make sure that when performing a risk assessment, that it's being completed by a competent individual. And I think whenever we're coming into a workplace, we all have a basic understanding of what is involved in a risk. We identify that something's in the way, we can remove that risk, we document it, and done. But there's a lot more detail that's involved, and especially as you work your way through management. And I guess at the level that I'm talking to you guys tonight, I would expect that you guys should be able to perform a thorough risk assessment, risk management, to be able to make sure that it's accurately completed. But I know that I wouldn't be able to walk into my partner's pub and do a risk assessment there, because I don't know their policies and their procedures, and I'm not competent in being able to carry out a risk assessment in that workplace. But I know that if I go down into my department here, that I know the ins and outs of this department, and I know what is expected, so that I can competently carry out that risk assessment. And once you've completed that risk assessment, you need to know who you need to speak to obviously try and either fix the hazard, improve the risk, decrease the chance of harm, or anything like that. And obviously, like I said, when we're performing a risk assessment, we want to be making sure that ideally that it's being done proactively as opposed to reactively. So the 5 steps to risk assessment are covered here, and there's no necessarily fixed rules on how a risk assessment should be completed. And it will be dependent on the nature of the work and the types of hazard and whatnot that are being identified. But these are the principles, the 5 steps that are outlined by the Health Safety Executive's 5 steps to risk assessment. And we're going to go through those now. So what can go wrong? So this is step 1. So obviously you can see here that somebody's, cutting a piece of metal, and we can see that there's some cylinder tanks here. And actually there's a chance that these could explode. But I guess this is something that is really obvious. And I think that's the difference between a basic risk assessment and actually taking this a step further, that it's not actually about the things that you can see. So I can see a hole in the ground. I can see when somebody has given the wrong medication and things like that. So we can always look around and see what may cause harm. But actually, it's not just about the things that you can see, but it's about the things that you can't see, which is where referring to sickness records and exit interviews to be able to identify those not so obvious risks. And I talk about exit interviews because obviously, if we think about attrition rates and the number of people that are leaving your department, I want to know why they're leaving the department, because actually maybe there is something that I can't physically see or that's not being spoken about that's really important that we need to identify and address, because the risk is I'm going to end up with no staff. The next step is obviously assessing the risks. So we need to look at who might be harmed and how. What are you already doing about that risk? So are there any controls in place? And there's quite a few terms about treatment of risks and things like that that we will go through tonight. What further action that you need to take to control that risk? Who needs to carry it out? So when we're thinking about who needs to carry out the action, I guess we're thinking about what can be covered by your line management, and then what needs to be covered by the overall health board. And those things obviously have to be escalated in an appropriate manner. But when you're thinking about line management, I know for a fact that if there is an observation machine that's not working down on the floor, then that is going to delay observations from being performed, and that's a safety aspect. So if somebody informs me of that, we have to replace that as line management. But I wouldn't expect my CEO to be ordering that observation equipment. However, if, you know, if we're looking at a department or a health board of more perspective, if patients are having consistently having elective surgeries cancelled, that is a risk to people. And actually, I can't control that as a line management. However, you know, it's that executive level that has influence over those kind of things. But we need to be obviously determine when the action is needed by. So, you know, it's actually making sure that we identify the hazards, but actually decide how likely is it that somebody could be harmed and how serious it could be. And then obviously we need to look at controlling the risks. So I sometimes think that this could be my partner because I feel like he's a danger to himself. He seems to trip over all the time. So I'd wrap him in bubble wrap. But how can I, you know, either decrease the consequence of a risk or remove the risk? And sometimes removing the risk is, you know, unlikely. It's not always expected that you would be able to eliminate the risk, but you need to be doing everything that's reasonably practical or to be able to protect people from harm. And that obviously means balancing the level of risk from the number of things that you need to put in control in terms of the risks. So if I can't, you know, how can I control the risk so far? So can I redesign the job? Can I replace equipment? Is there something that I can do for my work to make sure that people are having a reduction in exposure? Is there PPE that I can provide to make sure and making sure that people are wearing it? So obviously, if we bring it back to something that's quite relative at the moment, COVID, we know that if obviously we walked into a workplace right now, we weren't wearing any masks, any visors, eyewear, and whatnot, that we have a greater exposure to something that's quite potentially harmful. The next step is obviously recording your findings. And obviously the things that need to be recorded are the hazards, who might be harmed, and what are we doing to reduce or control the risks. The next one is obviously reviewing the controls. So the review part is obviously one of the most important elements. And it's making sure that we're reviewing to make sure, are they no longer effective, or have there been changes that have been made in the workplace to either that may even present new risks or may improve the existing risk. So if you think about, you know, these are the fundamentals of those basic risk assessments. So we know that we see a risk, we know who might be affected, we know how we can remove it, it's fixed, and this is a really nice basic understanding of risk assessment. So this here is obviously an example of a risk assessment form, and they're different for each workplace, but obviously there is a description of the risk, scores, controls, assurances, of which all these terms we're going to go through, gaps in control, gaps in assurances, and if there's any further action required. Has anyone got any questions before I continue on? No, cool. Okay. So when we talk about the risk management process, obviously this section middle encompasses a risk assessment. So that risk identification, the risk analysis, the risk evaluation, what we're going to do to treat the risk, and obviously that communication with the possibility of the people who are going to be able to help mitigate the risk or help eliminate it if that is possible. And obviously the monitoring and viewing of that, like I said, it's really essential, because obviously that monitoring in that review period helps to identify either new risks, new hazards, or actually possibly the fact that you may be able to remove that or decrease that risk score because things have started to improve. So the first phase of the risk management process is obviously establishing that context. And that's making sure that when you're describing that risk, it really needs to be quite accurate, succinct, and very structured. Because obviously this is going to be passed on to people that are able to help provide some kind of treatment to help mitigate it. You need to make sure that obviously it includes a summary of the relevant background facts, that obviously you describe the current existing conditions that create that risk. What is the consequence of the risk? And obviously that's how you develop a risk description. So it's considering the overall context in which other elements of risk process might occur. So considering internal and external factors. So when we think about internal factors, think about obviously the results of your audits. And obviously every department does audits, weekly, monthly and whatnot, but actually think about those outcomes of audits, because those outcomes of audits can be something that helps identify a risk. I know that every month I do basically 10 audits a month. And one of those audits is hand hygiene. And I know that obviously if I'm not getting 100% with hand hygiene, then there is a risk that obviously the people that aren't doing correct hand hygiene can have the potential to pass on and help create a hospital-acquired infection for patients, and that there's transmission of infection and whatnot. There's obviously, you need to think about from an internal factor, think about your local policies and procedures. And when you can identify that people aren't following those policies and procedures because they're being put there for a reason, they are in place for a reason to make sure that somebody is not exposed to a level of risk. But if we think about external factors, think about service user groups, legislation, we can see that if somebody's not following, an act, if I was sometimes a fly on a wall and I can see that people walk past something that's been placed right in the middle of the floor, or somebody that decides to put a bed in a corridor that doesn't have enough space for another bed. So if there was a resus incident or something like that, where an emergency people need to fly past, they're not going to be able to fit through that space. And that's a risk in itself. So if you're thinking about your service user groups, think about trade unions and whatnot, because they help identify those risks that we can't often see. So it's making sure that you consider both internal and external factors. When we're talking about good risk management, it's more than just about performing a good risk assessment. It's about making sure that you're communicating that effectively. And that's what I mean about having a succinct and structured risk description. There's nothing worse than taking a page to just describe the risk. It needs to be succinct. And obviously the monitoring of that is essential. And writing that risk description, it is similar to writing a story, because there is a beginning, a middle, and an end, but it's a succinct thing. So if we think about an example, you've got, let's say the context would be there are a new type of pump being implemented into the department. However, there is a cause that equipment is being used incorrectly because the staff haven't had training on this new pump. And the risk is that staff use the pump incorrectly. But the impact of that would be that medication errors result in patient harm. There's a complaint because there has been an error. It could be a notifiable incident. And obviously that's a statutory non-compliance because we're using a piece of equipment that we're not necessarily trained to use. But it's using that succinct approach, making sure that we encompass all the information that you need to be able to establish that context. So we're going to move on to thinking about the types of risks. And I briefly touched on, obviously, the terms operational, strategic. Now, I'll start with strategic because I'm not going to go too much into depth with that tonight. We're going to focus on operational because they're more of the things that you guys are going to see and deal with and manage. So if we're thinking about strategic risks, they are risks that represent a threat to a health board's or trust's overall objectives. Now, each health board, regardless of where you are, is relatively clear about their strategic objectives, and they're usually something that is achieved over the next 5 to 10 years. So for an example, I know that I work in Cardiff and Vale Health Board, so they've got a collection of strategic objectives. Some of those are to reduce health inequalities, to make sure that they have an unplanned emergency care system that provides the right care in the right place first time, and that we have a balanced care system where demand and capacity are in balance. I know that in Gloucester's health board, that they have a strategic objectives of driving research and digital future. But it's thinking about, so the things that impact on those risks are, the risk would be the health boards not achieving those goals. And sometimes it can be spread across both operational and strategic. So it doesn't just have to sometimes fall into one separate domain, it can fall into multiple domains. So if we're thinking about operational risks, we're talking about risks that impact on the day-to-day functioning of your department and that operational activity. And the risks that are covered in operational are generally the responsibility of the line management. So like I said, it might be broken equipment. It might be staffing. Mind you, I think staffing is a big questionable one at the moment. What about, is there anything else that you guys can think of that might be an operational risk that you see in your department that, you know, line management can fix? Any idea, guys?
Stunned into silence.
Yeah.
Have a think, folks. Don't think what, well, they can't or they won't, but just think,
okay,
what could they do to help? Go on then, Jacqueline.
Oh, yeah. I work in a minor injury unit, but if somebody presents and they're ticking on the COVID assessment, we bring them in through a different door. Now we have one room that we would sit them in because obviously they pose a risk.
Yeah.
So if that room is full, then anybody else that comes in and ticks COVID assessment positive, they sit on a bench that is outside the triage room, and that everybody has to go past to get to X-ray. So that would be a risk with people trotting back and forth from the main waiting room who have ticked as being negative risk for COVID, but they've got to keep coming past maybe two people sitting on the benches back and forth who are ticking COVID positive.
Yeah.
So it's the direction of where we need to think more widely about the direction that patients are put, or find a better solution to where you were putting these patients having to come back and forth in an area that where you have potentially an infection hazard.
So I want you to keep that in the back of your mind, Jacqueline, because as we continue to go through this tonight, I want you to be thinking about, obviously you've started to identify that risk, which is great, but actually I want you to think about all the other elements involved, and we'll come back to that later on, I think.
Right, thank you.
So we'll move on to the risk identification. So we've obviously established the context. We have an understanding of now what is operational and what is strategic, but this part is obviously the most critical. And in that risk identification, so if we're thinking about those 5 steps of risk assessment, this encompasses almost the part 1 and part 2. And this, obviously the process of risk identification is obviously the extent and the nature of the risk, the circumstances under which the risks may arise, and the causes and potential contributing factors. So why is this stage so critical? And I think what we need to explain is, without sound understanding of the risk, the remainder of the assessment is actually quite a flawed process. And that's where obviously that establishing the context and making sure that you fully have identified that risk is really important. So like I said previously, it's not just obviously the people, it's more than patients, safety, staff, the public. It's also about, you know, possible reputation risks. And I'll talk more about some of those elements in a little bit. There's risks to obviously the quality of service provided by the hospital. So I've briefly touched on staffing levels. So I know that when we're talking about obviously risks that impact on the ability to deliver safe and quality care, I think it's a current topic at the moment to think about staffing levels. So if we don't have a safe staffing level in the emergency department, you're not only unable to achieve health and care standards. So we're thinking about timely care, safe care. It's unlikely that your simple risk assessments are often not being completed. And when I talk about those simple risk assessments, it doesn't make them any less essential. So we're talking about your water low or those elements that can actually cause patient harm. If we think about, so that's staffing, and staffing we could talk about for a long time, but obviously that is a risk at the moment. And what are we doing to help mitigate those gaps in staffing? So I know that we're pulling management, we're pulling other services that we would normally be able to deliver in the department, but at the moment we're not delivering those. If you think about, and I will talk about, if we think about government measures, so obviously the 4-hour target, they were developed on the basis of risk. It's not just a number that the government have just come up with and decided, you know what, we're just going to make sure patients are out of the department within 4 hours. That target and that measure was based on, qualitative research and quantitative research to show that actually we know that if patients stay in the department for more than 4 hours, there's a greater chance of medication errors, there's an increased stress to staff, and we know that there's a greater mortality of patients staying in emergency departments for a prolonged period of time. So what have they done to help remove that risk? Well, they've created that 4-hour target to help, move patients through the department in a timely manner so that those risks don't start occurring. We know that we need to be able to identify risks that may impact on competence or organizational development, and obviously risk to reputation and finances. I guess the other thing that we need to understand is that a risk doesn't just have to cover only one of those elements. It can cover and encompass a lot more of those domains and categories. So for example, a safety incident may result in injury to a patient, but could also breach health and safety law, which could result in a financial risk, because obviously we haven't covered that. Just apologies, there is a helicopter about to land and my office sits right next to the helipad, so it might get a bit noisy in a second. So this safety incident may result in injury, but also there could be a breach to health and safety law resulting in a financial impact. But also because of that, you may get a poor press coverage, which harms obviously the reputation. And just to reinforce, obviously with risks, we would like to be more proactive than reactive, which we're going to go into now. So there is a proactive and reactive element, and proactive is obviously identifying actual or potential hazards and ensuring that we put adequate control measures in place to mitigate that risk. There is obviously, if we're doing proactive risk assessment, there's often a requirement to meet statutory duties, so to make sure that we're covering those health and safety standards. And the aim is always to be proactive about this, because obviously the earlier that we identify the risk, we can either prevent it from occurring or reduce the likelihood of the risk actually taking place. So I briefly touched on a simple risk assessment before. If you think about water load, performing a water load, we know that if we complete that ideally within 4 hours of arrival to the department, if a patient is at risk of pressure injury, that actually there's a risk score and then usually a set things that we should put in place to help prevent that breakdown of skin. So you might order a different mattress, you might initiate intentional roundings and making sure that you're turning your patients every 2 to 4 hours or relative to what their risk score might be. It might be that you need to arrange medical photography, all those things to make sure that, you know, that is a basic risk assessment. If we're thinking about health and safety audits, we're thinking about a fire risk assessment. So making sure that corridors are clear, making sure that there's not much paper copies on your walls, because obviously a fire can catch easier with that, making sure that oxygen cylinders are stored appropriately and in line with guidance. And then obviously when we're talking about the proactive element, we can think about accreditation processes. So obviously in Wales, we have HRW, so the Health Inspectorate of Wales, and I know in England, they've got the Care Quality Commission. So even though people, like as a department, we often get quite concerned about some of those people coming in to accredit those department, but actually sometimes it can be a really, most of the time it's actually quite positive, because although there are things that we know occur and happen and we try and prevent, sometimes there are things that we can't see, and actually it takes an external set of eyes to be able to identify those elements to help get a ball rolling, to be able to prevent and be proactive about that. When we're talking about reactive risk assessment, it's not always feasible to be proactive. We can't always prevent everything from occurring because maybe we haven't been able to identify that. And that's obviously a reactive risk assessment will take place after an adverse event or a near miss from occurring. And then actually once it's occurred, hopefully we can reduce the likelihood of a similar event occurring again or the impact of any repeat event. So ideally, we'd like to reduce the consequence, but sometimes that's really challenging, but hopefully we can reduce the likelihood of it occurring again. And a reactive, if we think about reactive assessments, we can perform those through root cause analysis and identify the risks, and then we can perform a structured risk assessment. But obviously there can be multiple contributing factors. And quite often people focus on incident reporting and things like that to identify risks. But, you know, it's like I said, it's not sometimes the things that you see, it's about sometimes the things that you don't see. And that's where concerns, people phoning in about concerns with departments can be really beneficial, because actually sometimes if they highlight things, it's maybe something that we haven't been able to identify, and it helps us to continue to make positive change and put things in place so that those events, those risk events, don't occur again. So the next stage is a risk analysis. And obviously, so we've established the context, we've identified the risk, and we now move on to risk analysis. And that's being able to understand the nature of the risk, the level of threat that it poses, and if there's multiple causes and consequences of said risk. And there are obviously varying degrees of detail and complexity depending on the risk. And actually being able to do an analysis of that risk depends on a number of things. So when we look at risk analysis, we need to work out the likelihood of that risk occurring, the magnitude or the consequences of that risk will have to either the people, health board, whatnot, that complexity of the risk, and does it have, you know, connection to multiple other risks, other objectives? Are there any time-related factors that may influence the likelihood or consequences? And how are we, as a management, going to be able to provide assurances that we have put controls in place to help mitigate that risk? So when we're talking about assurances are ways that of delivering basically proof that the controls that we've put in place are being effective, and that we've got data to be able to prove that. When we're doing a risk analysis, and we're collecting, you know, data and information about that risk, it can be both qualitative and quantitative data, and it depends on the circumstances of its use. So when we look at quantitative, and I go back to that hole in the footpath, that 50 people in the last month have tripped in that hole. And I know that because there is a number of incidents reported. However, I know that I've put something in place and the number of incidents about that hole in the footpath has now reduced significantly. If I think from a qualitative perspective, I'm going to think about attrition rates. So the staff that might be leaving the department. So there is a dual perspective there of both quantitative data and qualitative. So the quantitative is, I know that in the last month, and this is not accurate on reflecting on my department, I've had 25 people leave in the last month. And I know that that is a black and white number. I've got 25 people that have left. So that's the quantitative data. However, if I look at their exit interviews, or, you know, based on a conversation about why are they leaving the department, that is a description, and that's more of a qualitative perspective, because I want to understand why are they leaving, because the risk is if I don't do something about that, the chance is I'm going to end up with no staff. And obviously, that poses a threat to multiple other things. It means that I can't provide the proper care, I can't staff shifts, all of those elements. So you need to think about how you're going to analyze that risk. And I guess when you've got that information, and let's use the exit interviews and attrition rates, for example, that if we're looking at that data, it can be perceived quite differently to multiple different people, and that can introduce bias. And actually, I guess that's the same with risk analysis. If, when I look at a risk, or possibly when Jeanette looks at a risk, our opinions and biases may have a different degree of perceptions relating to that risk. And that's where we're going to go through, obviously, more detailed elements about consequences and likelihood, because actually it's a lot more set out to try and remove that bias and remove that varying degrees of perception. Obviously, the way that we perform our risk analysis provides a significant amount of impact on how we evaluate and what needs to occur to be able to put in appropriate treatments or strategies or methods to be able to reduce the consequence or the likelihood of that risk. So I thought here would be a good time to pause for the moment and have a quick break before I go into risk evaluation. Okay, so we're going to head on to risk evaluation. So risk evaluation involves obviously comparing what has occurred in the risk analysis with a established risk criteria, and that is to help obviously determine what happens next. So with a risk evaluation, there are 4 options really that can be, or actually 5 options that can be taken in risk evaluation. So the first point that I want to make is that maybe further analysis is needed to create better understanding. And I guess that's where those first couple of steps are so vital to this process, especially with the risk identification, because if there is, if that risk identification hasn't been fully developed or there is a lack of understanding, then obviously that impacts the process as it goes on. There is, you can terminate the risk, which means removing the risk altogether, or being able to do things differently in your practices so that that risk doesn't become an issue. Or you can make sure that there is a risk toleration so that you accept the risk as it is without taking any action. And that's usually, there is some kind of level of risk toleration with some elements. So, if we, and I'm going to use staffing as an example again, I know that if I'm one staff member short, that although that will have an impact, it won't dramatically change my ability to be able to deliver a service. And I can look at probably being able to continue my service without having to pull someone else into those numbers. It doesn't make it right, but actually we can probably accept that risk. There is the option to be able to treat it. So treat is probably the most common term that we're going to refer to, and that's obviously about putting in controls to reduce the likelihood or minimize the impacts to the consequence of that risk. There is also the term, obviously, to transfer. And that's obviously about more higher level things where it might be that you're putting insurance in place so that that company is willing to take the risk on behalf of the organization. So if we're talking about toleration, okay, there's a term called risk appetite, and that obviously it refers to the amount and type of risk that an organization is prepared to take. So as an organization, like I said, having one staff member short is not ideal. We don't want to be one staff member short. And things that we would do is we'd go out for temporary staffing. We would make sure that we would see if anyone would like to work overtime, if anyone would like to work bank, any of those options, we would seek those things. However, if we were not able to fill that spot, then that is something that we'd probably accept as an organization, that we're working one staff member short. I mean, at the moment, if I was working one staff member short, I would be almost jumping for joy rather than 50% of my staff. That'd be quite a significant, great day. I guess the other thing is, obviously, you need to be able to have an understanding of what are you looking at putting in place to be able to help mitigate that risk and help control it, because obviously there needs to be a fine balance in between being too excessively cautious, but also making sure that you put things in place that you are able to decrease the consequence or the likeliness from occurring. The other thing is, you need to think about risk proximity. So obviously, when we're talking about the term risk proximity, it's about thinking about consideration of a time period in which risk events might occur. So I know that in March, we have the Six Nations and a lot of rugby games in Wales. And I know that there is a chance that the number of presentations on a Friday, Saturday, and Sunday night are going to be much higher with alcohol intoxication, assaults and injuries and things like that. So there is a risk that, you know, the department might be overwhelmed. There's a risk that there might be an increase in violence and aggression towards my staff. So what am I going to do about that proactively to try and reduce that risk on the staff? And then when we talk about transferring risk, like I said, that's more of a higher level thing that's related to financial management and things like that. So we're going to go on to risk scoring, and this is obviously really, really important. So when we're talking about risk scoring, we complete a risk score multiple times throughout an assessment, throughout the management of a risk. So we perform an initial risk score, and that is calculated without any controls in place. So it should represent the worst case scenario. So if we're looking at the risk, if we're, you know, dealing with the risk, it should be without anything in place, nothing to fix it. It is the worst that it could possibly be. And we need to consider, obviously, how many, with this risk, how many of the domains are relevant to this risk, and what is the potential consequence of that risk. And the risk scoring is obviously put in place to determine the overall level of risk. So it's looking at the likelihood. So when is it going to occur, or how often is it likely to occur? But also we look at the consequence. And we're going to look at the consequences first. And obviously I've dropped the term domains a number of times. So we're going to look at some of those domains that are relevant to healthcare. So sorry, I couldn't make this this any bigger. So the first domain that we're going to look at is obviously the impact of the safety of patients, staff, or the public. And that can be obviously physical or psychological harm. And when we look at the consequences, it is a numerical score by considering the severity of the risk on the scale of negligible, which is a 1, to catastrophic. So if we look at negligible, it might be that there's probably no or minimal intervention that needs to be done, that if it was a staff member, they don't have any time off work. Where if we go to the other end of the scale, catastrophic is an incident that's likely to lead to death or have permanent irreversible effects, and the event of which impacts like a large number of people. So in relation to, like, if we look at a RIDDOR, so a RIDDOR, you would be completing on an accident that is identifiable as it's an unintended incident, and it can cause injury, but it doesn't have to be physical injury. It can be psychological injury as well. For example, violence and aggression in the workplace. So when we're thinking about violence and aggression, there is a significant impact on the staff, and that can have, you know, especially at the moment, what we have found in our department, that the rate of violence and aggression seems to have, you know, increased by about 30% in the last 12 to 18 months. And I guess that probably is in relation to, you know, increased waiting times, which is happening across, I suspect, not just in the department that I work in, but across the entire UK. There's increased waiting times, increased number of people presenting to the department. So there's overcrowding and whatnot. So, you know, because there is a cumulative exposure to violence and aggression, we need to be looking at obviously the consequence of that. Obviously, the next one is quality complaints and audits. So when we look at the quality complaints and audits, we're looking at, obviously, if you're doing your monthly audits, are they complying with national standards? Are they complying with regulation acts, legislation? If we're thinking about concerns, is this a concern that's been raised, and, you know, what they're seeking as an outcome of that concern is a conversation with management in that department. So I can give them a call and say, you know, I'm really sorry that was your experience on this occasion. This is actually maybe something that we're already doing about it. Or are they looking for, you know, that we haven't met national standards and that they're going to take us down, you know, an independent review, legal action and things like that. So another domain would be human resources, organization, staffing, competence. So it's interesting if you actually look at this. This would come under where you've got your staffing levels. So what is the consequence of maybe having one staff member short? But actually, we know that at the moment, we're probably sitting well up here in these figures of consistently being short-staffed at the moment. And that's for multiple of reasons. It's for COVID. We know that it was predicted, going with Omicron figures, that there was a chance we were going to lose 30% of our staff. And I think that's almost been pretty accurate with COVID. But obviously this prolonged exposure of consistent stress and demand on the health system is starting to cause really low staff morale, because you know, because our staffing levels are so short, we can't send people on educational programs and things like that, so they don't feel necessarily as invested in or whatnot. So you need to look at those organizational development issues. When we talk about statutory duty and inspections, obviously we're talking about, making sure that we meet fire assessments, legislation. It's all about obviously meeting those acts and regulations that we have to follow in the health system. Could there be that there's adverse publicity and reflects really poor on the reputation of the health board? Because that is an important domain. People want to be able to trust the place that they're going into to receive the care. They don't want to not be able to trust us. So publicity and reputation is actually really important. We need to look at obviously business objectives, and that's where I was talking about those strategic elements. Are the things that we're doing at the moment helping to support the health board to meet those strategic objectives? So for us, everything that we're doing, are we helping to support health inequalities or reducing the number of health inequalities in the local area? Financial claims I probably don't need to go into. As you can see, that somebody may claim a financial benefit. And when we think about small loss or risk of claims, it might be that a patient's come into the department and when they've gone back home, they've found that their glasses have been missing. So it might be that there is service business interruption. So if a fire was to catch a light in one of my majors areas, that may cause an interruption of more than a week, which is really disruptive, and that can have a significant consequence. And obviously we also need to consider environmental impacts as well. So we're talking about consequences here. So what is the consequence that has occurred from that identified risk? And then obviously we need to consider the likelihood. So how often is it likely to occur? Is it going to occur hardly ever, in which case it might be considered rare? Or is it occurring every single day consistently in the department? So likelihood is measured by considering how often that event is likely to occur on a scale of 1 to 5, rare to almost certain. And then as a result, once you've looked at your consequence and your likelihood, those two figures are then multiplied to give the initial risk rating. And this occurs obviously multiple times throughout the risk management process. So like I said, a score should be completed initially without any controls in place. So worst case scenario. Once you've put some form of treatment or control in place to help mitigate that risk, another risk score should be taken. And realistically, not always, but most of the time the consequence sometimes doesn't change, but actually with effective controls in place, it should decrease the likelihood of that risk occurring. So the overall score should be lower. If we're thinking about, so you've got your initial risk score, a risk score with controls in place, but then we have a target risk rating. And that risk rating is basically the level of risk that the department is willing to accept or tolerate. So that risk appetite comes back into play. So how much of a risk are we willing to accept with this? And that's obviously really relative with your current risk score, and that might be the one with your controls in place. Because obviously if there's a difference between your target risk score and your target risk score and your current risk score, then that should initiate the development of an action plan. What else do we necessarily need to do to make sure that we are meeting that target risk score? And how much is we need to be practical about what can be put in place, and so that it's not unrealistic and that it's achievable. So if your score comes out between a 15 and a 25, then those kind of risks, are really concerning, and they are the ones that should be escalated to clinical board. So if it was you guys doing it now as a management team, you guys could be escalating to your senior management team, your general manager, your service manager, the people who can make a change, and who is going to take ownership of that, because it might be that you are unable to do something about it immediately, but actually the right people that need to be escalated. And actually what is important is to understand that even though you may not be able to change that situation straight away, but actually it's those first few couple of steps that are really important, that actually you can establish that context, that you can identify the risk, you can analyze the risk, you can come up with an accurate score of that current risk. And actually you can present that information to your senior management team and say, this is what I found. I've accurately described it. It's succinct, and that is clearly evident on that record that you've given to them. So even though you might think, well, I can't change this, but actually your influence is really pivotal in the ability to change it because you've accurately described it. If you're thinking about risks that come out as a high risk, so whilst it's not an extreme risk, which means it probably doesn't happen every day, it's still really concerning and it does need to be escalated. Your moderate risks are more likely to be things that can be sorted by possibly within your directorate or within your clinical board, where you might need to mention to your service managers and things like that, and we can get something in place to be able to sort that. And then obviously you've got your low risks, which doesn't mean that it is not important. It just means that it's probably likely that it can be managed within local policies. So like I said, if the current risk score is still higher than the target risk score, then that would lead on to the development of an action plan. So when we talk about risk treatment, so risk treatment are the things that we're going to put in place to reduce, obviously, those negative effects. So we talk about mitigation and things like that. And risk treatment is obviously about planning and implementing that mitigation so that it is embedded properly and effectively into your service or to help reduce the risk. You need to make sure that you're assessing the effectiveness of that treatment, and that will come more with the monitoring and the reviewing, but you need to make sure that you decide whether the risk is acceptable with those current treatments. And obviously the monitoring and review of that of the implementation of that control is really important, because obviously risk is dynamic, it is constantly changing, and that can be sometimes for the better or it can be sometimes for the worse, of which then you can do something about it. So when we're thinking about controls, your controls are things, any active measure that modifies the risks in an intended manner. So you can have two types of controls. You can have pre-event controls that is likely to reduce the likelihood of a risk occurring. So that's us being proactive about something. Or you can look at something that is a post-event control, so reducing the consequence of a risk if it does occur. And obviously understanding the difference between that may help guide and help prioritize what is important at that time and what are you trying to achieve. But controls that you can put in place might be the development of a new policy, the new procedure. It might be that you look at new technologies, new techniques, and methods of doing things. So an example, obviously, a pre-event, and if we think about driving a vehicle, so using your brakes when you're driving means that there's less chance that you're going to hit the back of the car. But if you do hit the back of a car, then the post-event control is that you're wearing a seatbelt. Okay, so the idea is that you don't want to hit the back of a car, But if you do happen to hit it, then there is a seatbelt in place to help cause any injury. If I think about examples for myself, I think about if I'm going out drinking, that I want to make sure that I'm drinking water and electrolytes before I go out. And I like, try and balance this. If I have a vodka in one hand or a martini in one hand, then the other hand, I have a glass of water. That's me preempting that I want to prevent me trying to have a hangover the next day. However, as a post-event, well, I've got the hangover, but luckily I've got paracetamol and I can take that for my headache. Okay, so that's your post-event control. And if we're thinking about some of these controls, they can take a while to be embedded into practice. So when if you were to embed a new policy or a new procedure, people are not going to learn that overnight. And I think that's something that we need to take into consideration, that sometimes it takes a little bit of time for these controls to be put into practice and being successfully used. So I guess you need to consider what we call gaps in controls. So making sure that we have consideration that sometimes that these controls might be absent or ineffective for a period of time, but it is, we can say that it is likely to improve, and we're going to make sure that we're reviewing and monitoring that situation to make sure that we do regain control of that risk. So a further example of a control, and I'm talking about a cannula here. So as a pre-event control, we know that if I send my staff on training to be able to insert a cannula, that they get trained to do aseptic non-touch technique. They get, and as part of that, they know that once they've cleaned the area or the key site, that as long as they don't touch that area again, that they're following that appropriate training, and that the risk of hospital-acquired infection, as long as they're abiding by those processes, is likely to be reduced. However, as a post-event control, we do VIP scores. So after the insertion of a cannula, we know that a cannula should only be in place for 72 hours as a maximum, and then it should be resited. But we know that we should be, after inserting a cannula, making sure that we're flushing and reviewing that cannula every 8 hours to make sure that we're checking for any inflammation, pain, patency, and things like that. So that's a post-event control. We can make sure that we're keeping an eye on the actual site to make sure that we reduce the consequence if that infection starts to occur, because as soon as we identify that there's any redness, we can take the cannula out and hopefully prevent an infection from occurring. I don't know if we can go without talking about COVID from an entire topic, can we? So if we think about COVID, a pre-event control would be, we know that if we wear masks, especially if, in a normal setting, if we wear a surgical mask and that we social distance, then that should reduce the likelihood of us catching COVID. If we're doing AGP procedures and things like that, we know that that we need to be wearing FFP3 masks, wearing visors, and making sure that we're not touching our face. We're donning and doffing and using those appropriate procedures. As a post-event control, that's where a vaccination has been put in place. So we know that obviously masks and social distance is reducing the likelihood that we would get COVID. But we know that as long as we've had a vaccination, that a vaccination decreases the consequences of if we were to catch COVID, because obviously we can see that the differences between wave 1 and the wave that we're going through now, that there are far less admissions to intensive care than there was in the first wave. And that's because the majority of the population are vaccinated. So there is a reduction in the consequence. So we've collated all this information. We've established the context, we've identified the risk, we've analyzed the risk, we've evaluated it, we've talked about treatments, we've put things in place. But where does this information go? So you guys have recorded all of that on your lovely risk assessment sheet that I showed before. So we've looked at all of those elements, but when you bring it to your senior management team, where does that information go? So what is the next step? And obviously that's really important with the recording of that information, and it is really pivotal in risk management, because that leads on to your monitoring and your review. So like I said, risk is not static, it's dynamic and it's evolutionary. And we know that because obviously as we review a risk assessment, we can either see that things have improved, or a new risk has been identified of which we need to do something about, and it might relate to a current risk. But that continuous monitoring is essential with a risk. So that information throughout a department is usually placed on a risk register, and it's reviewed on a regular basis due to its dynamic nature. So every 3 to 6 months, because I mean, in my position now, I am responsible for reviewing risk management. So every 3 to 6 months, I look at every single element on my risk register and make sure that I go and review that risk to make sure, are the controls that we've got in place, are they being effective? Do we need to do something else? Or have we met our target risk? And therefore, maybe I can look at removing it off the risk register. So the risk register contains all those details that we've spoken about. So the risk description, the initial risk rating, what the risk analysis, so what have we done about it? What are we putting in place? The current risk score with controls in place. And then obviously if there's a difference between that current risk score and your target risk score, what's the action plan and how are we going to achieve that? But actually the difference is with a risk register, we put someone's name against it. Who is responsible in your area to continue to decrease that risk, to try and work towards meeting that target risk? And when are we going to review it? Because like I said, sometimes when we put controls and mitigation in place, that's not going to be, be able to be achieved overnight. So saying that I'm going to review it tomorrow is probably not a realistic review date. Actually probably need to review it in, say, a month, 3 months time to see that it has been effective. If we can see that, before that, it's definitely not working and we need to do something else about it, then we can do something about it. So this risk register is obviously a central collation of risks, and each risk is assigned a risk owner. And a lot of the risks that are extremely high, or usually your moderately high risks, are stored at a corporate level. So this is just a very brief example of a risk. So for an example, the risk is that of COVID transmission to patients that are presenting to the emergency unit. And I think this is actually probably relevant, Jacqueline, to what you were saying about your patients coming into the department. And obviously you've identified that a person might have a cardinal sign and symptom of COVID, and you only have one space to be able to assess them. So they have to sit on a bench. But actually, even though they might have a cardinal sign and symptom of COVID, it doesn't mean that they do have COVID, because obviously some people come in with a temperature, but their temperature might be actually relating to the fact that they've got cellulitis, or they've got a urinary tract infection for multiple other reasons. I have a cough, but that's because I've got asthma. It doesn't mean that I've got a cough because I've got COVID. But actually, we have to look at that risk and how much we're willing to accept. So if we look at this, patients are presenting to the department with symptoms of COVID and without symptoms. But patients that have symptoms of COVID, those cardinal symptoms are put in a singular area because it's considered that until proven otherwise, people have COVID these days. Okay, but there is a chance that those people that don't have COVID and that have those differential diagnosis, that they may actually then end up with COVID as a result. So what are the things, you know, and that the consequence of that, if we think about before vaccinations, before we knew what we know now, that actually that consequence could be the difference between life and death. But actually, and the likelihood of that occurring, if we're mixing those patients without any mitigation in place, the likelihood is that we know that it's really contagious. The likeliness is they'd catch it. So what are the controls? What are we doing and what are we putting in place? So we've put a screening system in place, and that screening system is that, okay, yes, we still identify the cardinal signs and symptoms. So if you've got a cough, shortness of breath, temperature, loss of taste, whatever, and those people who don't have any of those symptoms, we split them, don't we? We put them in different areas. So we've got a screening process. What else can we do? So we know that if we encourage social distancing, that there is a reduction, then that there is a less chance that they may catch it. But also we've then got another control that we can put in place, that instead of patients coming in and wearing their own masks, that all patients coming in have to be given a surgical grade mask. So the ones that we give because we know that they're more effective, and that we develop a social distancing and an escalation in place. So if we know that that seat that's outside that room can only seat 3 people with effective social distancing in place, then what are we going to do if they get to 3 people? What's the next level of escalation? But they're the controls that we can put in place. So that's a control. And if we look at the current risk rating, we say those controls in place, the consequence is, well, if somebody still catches COVID, and I'm using the example obviously before vaccinations were in place, the consequence could still be that it could be damaging. They could still die of catching COVID, but actually the likelihood of them catching it could be reduced because we have put those controls in place. Okay, so even though we can't eliminate this risk, it would be an unrealistic target to eliminate that, but we can put things in place to try and to mitigate it. So they are your controls. Now, when we talk about assurances are obviously that data that I spoke about, the data that we can provide to the clinical board, to the health board, to senior management, that this control that we've put in place is effective and meeting what we need to do. So for me to be able to provide those assurances, I'm going to do a daily review of the footprint and the demand that is required in there. So I'm going to make sure that every day, the people that are being screened to go into your purple area, that are sitting on those chairs outside that room, that it is no higher than 3. On the days that we know that it's higher than 3, what did we do? Did we use escalation appropriately and things like that? But I can give that physical quantitative data to the people to say, well, this is what we've done, and this is how we're proving that we have done it. In terms of your gaps in control, so you've put your controls in place, but there might be a gap. So the gap can refer to anything that is absent or ineffective in that risk treatment. So I can still screen those patients and separate the cardinal signs and symptoms from the ones that don't have any, that are non-symptomatic. However, we know that patients can present with COVID that are asymptomatic. So I've just put an asymptomatic COVID patient with someone that doesn't have COVID at all and is like doesn't have the symptoms, but actually they can still pass that COVID on. So there is still a risk. So that is a gap in control because I can't control that. Okay, so I can put things in place, but it doesn't mean some of those elements are out of my control. When we're talking about gaps in assurances, we're talking about things that where there is insufficient evidence to demonstrate that a control is working effectively. So it might be that a gap in assurance here is that I still don't have, because patients come into your minor injury department, Jacqueline, and they come in, and even though we can see that we can keep an eye on the number of people that are presenting to the department, we can review that data, and we can ask the patients, how was your experience? Was it okay? Did you feel safe? But actually, there is a gap in assurances there because I actually don't know what's going to happen in a couple of days' time, whether they will become symptomatic of COVID. So there is that gap in assurance. Now, the target risk rating, obviously, are we ever going to be able to reduce the consequence? I mean, yes, now that there's a vaccination in place, but we're talking about pre-vaccination times. The consequence is always going to be really high because we don't know the way that each individual response to COVID is going to be different. So the consequence is always going to remain quite high because it is the matter of life and death. But actually, I would ideally like to reduce it completely so that that isn't an option. I'd like to have like to have 10 individual cubicles so that if you had 10 people present to the department that had the cardinal signs and symptoms, that we could put those people in individual rooms so that they weren't exposed to anyone else. And we know that that would reduce the likelihood. Is that realistic? Because I know that obviously there is a difference between my current risk rating and my target risk rating. So the action would be, I want to build another hospital and I want to do it in 3 months' time. Is that realistic? Is that a realistic action? No, unless you're probably in countries where I think, didn't China whip up a hospital in a week or something like that? I think that's
Yeah, they did a kind of prefab locked together stuff.
See?
They bolted everything together very quickly. But yes, they did do it in about 10 days. Yeah. But then you have to think how quickly the British military put together the Nightingale hospitals. Admittedly, true. There were walls and a ceiling already in walls and a roof already in place, but they put those Nightingale hospitals together very, very quickly.
They did actually. So I guess we need to just consider though, that if we're going to develop actions to help focus on that target risk rating, that those actions have to be smart. So they need to be specific, they need to be measurable, they need to be assignable, realistic, and they need to be time related. And all of those actions have to be assigned a risk owner. And it's their responsibility to help work towards those actions. If we get to a point where actually the current risk rating is the same as the target risk, and you're happy that actually, you know what, we've either eliminated that risk or we've gotten to a point in that risk where we're willing to accept it. So we've met that appetite. Then actually, if you want to remove something off the risk register, it's not actually removed. It remains current for 12 months on a risk register after being deemed, you know, that we've achieved that risk. And that's because we need to make sure that we're reviewing it so that it doesn't become a risk again. And it's that, obviously, you know, reinforcing the fact that risk management is a dynamic process and that we're always constantly reviewing. So now is the time to come back to what I said to you before, Jacqueline, about thinking about your own practice. I want you to have just a quick 5-minute think about something that's in your own practice right now. And obviously, I don't expect you to come up with a full detailed risk assessment, but I want you to think about, you know, what is the risk? What do you think that you could possibly do about it? Just a simple 5-minute one. What do you think the possible current risk rating is? And what do you think you can put in place to possibly reduce that risk?
Let's just repeat those questions, Jenna.
Yeah, so think about something that is happening in your workplace, okay? And it can be something that we've already gone over. It can be something like mask wearing. Do you think that people are effectively wearing their masks, that they're not, you know, getting a little bit lapse with their processes and whatnot? But think about something that is a risk in your department at the moment. Think about what you can do to try and reduce that risk, and think about that risk rating. So where do you think, is it an exceptional risk? Is it a high-ish risk? Is it a medium risk, or it is a low risk? Just think about those couple of elements. Has anyone come up with a bit of an idea? And is happy to share. Jacqueline, I think you're on mute if you're trying to talk.
Okay, thank you. Going back to visitors and the number of visitors and relatives, or and again about the unproven exemptions to mask wearing that seem to come our way, and they say, I'm exempt. We have no evidence that they're exempt. You having to take it at face value, or you could say, well, I'm terribly sorry. You know, I think that proves a great risk when you know, somebody is telling you that they're exempt. We have no evidence that they're exempt. So do we have to just accept that?
Yeah,
so I think that poses a risk.
It does. And I think it's funny, I came across this situation this week actually, where a practitioner had phoned me and said, there is a patient that is unwilling to wear a mask. And it put me in quite a difficult situation, because I guess with that situation, we have to consider, well, you've got to weigh up the risks as well. If we don't treat that patient, there is actually something wrong with them, are we bringing in a different risk there? So what is something that we can put in place to mitigate the risk? And actually the person that you're looking after in that situation is you. It's yourself in that situation, because obviously you've got somebody that's not willing to wear a mask, but actually what are you going to do about being able to look after yourself? So what control are you going to put in place? So if that was you, what would you do?
I would suggest that they try a visor instead of a mask, or I would have to go into a greater degree of PPE, and try and get this patient to be away from the general population.
Yeah.
So I'm going to, I just wonder what your thoughts is now. I don't want to sidetrack completely, because I'm finding this very interesting, Jenna, about unvaccinated staff in terms of risk.
Yeah, and I guess that's their own risk acceptance, because actually I think there's a lot of detail and data out there now for people to be able to make an educated choice. And I'm not going to preach to anyone about the choices that they choose to make, because that's an individual choice. But the evidence is out there that we know that if somebody is vaccinated, we can see with the numbers. And like I said, compared to the first wave to this wave, I can see that the number of ITU admissions that I've had from the department is significantly lower than the first wave. However, each person is entitled to their own individual choices about what they do. And I guess that is their own risk acceptance, that if they come into a workplace that is a high risk, because we work in places in healthcare, we are high risk places of exposure to COVID, and especially for those that work in, resus departments and things like that, they're exposed to aerosol generating procedures, so the risk is higher. But if that individual staff member is willing to take that risk, then they have to weigh up those also those individual consequences, because actually we know that the consequence might be quite terrible for that person who chooses not to put in a control. Okay, and that control is a vaccination, but that comes down to an individual choice.
Even though the impact can be felt on other staff members and the organisation. And does that come under, I was interested in your risk tolerance. I mean, I don't want this just to be about COVID, but England is saying that their staff, if they're not vaccinated, potentially could lose their job. So they're prepared to risk tolerate, are they? I find this quite, this is a full-time job almost, isn't it? Risk.
It really is. And
yeah,
actually,
once you start, it's fascinating actually.
Yeah, and that's the thing that, so in my role as a senior nurse at the moment, we have different portfolios, and one of my portfolios is quality and safety and risk management. And risk management alone is such a big job, because actually, like I said, there are so many things that jump up at you, and there are different elements. So obviously we did a COVID action plan, so things that we're putting in place to make sure that we help support the risk towards staff and patients, and policies and processes, so that, you know, that was quite detailed. But it's other things like how much budget we're getting towards a training program, that is that actually meeting the needs, the training needs for the department as a whole. And if there's a gap in there, then that is a risk, because it means that my staff may not be able to attend courses because we don't have the funding to be able to send them on that. And that's a risk, because they may not have the skills to be able to do that task that is relevant to their job. So there's lots of things that actually we need to take into consideration of risk. And that's why I really do want to focus on the fact that it's not just about the things that you see, it's about the things that you don't see as well. And that's sometimes possibly the things that you don't see. And those, if we look at things right now, it's almost like you couldn't blame a nurse for leaving their job at the moment, because of those continued and unsustainable pressures that we're all facing in the healthcare system, that actually it gets to a point where they can't handle that anymore. But the risk is that I don't want my staff to leave. You know, that is a risk that staff will leave. But what can I do to help staff feel valued, to support their well-being, to make sure that they want to stay in work and not leave their job? But that's not something that I can put a quantitative value on. That's something that is completely qualitative.
Quite.
No?
Yeah.
And I guess that's where the unvaccination thing is quite a controversial topic, of which is really individual, that I think will be argued for a lifetime to come yet. So I think that's a huge topic. But I think that's, it's relevant to bring up as well, because I think that's a concern for all of us that are working in healthcare. Which is actually good, because if we're going to talk about infection control, we may as well go on to the next bit. And we're just going to, it was just an example of putting things in place. So you guys are all obviously senior members of staff of some level, and think about, obviously, if you're going into your workplace, how are you going to make sure that your staff are actually completing their risk assessments? And it might be it's that difference between performing a basic risk assessment and the level of risk assessment that I would expect from a manager. So as a band 7 in the department, I would expect a very clear, accurate risk assessment of the level of detail that we've gone through tonight. But actually, I think that would be a pretty unrealistic expectation of my band 5s to be able to do that, because they may not have that understanding to be able to do it. So actually, what influence can you have as band 7s having that background knowledge to make sure that even your risk assessment, such as infection control risk assessments or your water lows, your falls risk assessments, are being done in an accurate time fashion? Because they are so pivotal to the quality and safety of that patient's journey through your department and onwards. Because if it's not identified at the beginning, so using Waterloo as an example, you know, what if a patient doesn't have a full skin check done? What if they're not rolled and actually they do have a grade 3 or grade 4, but it's just been said their skin's intact, nothing's wrong with them, and then actually don't instigate the appropriate things that are in place? And that's where it goes back to me saying that that risk identification is the most critical phase of this process, because as long as you can create a complete picture that is accurate and describes the proper risk and the people that are involved in that risk, the rest of the steps can follow, because you can put something in place. But unless it's identified, the rest of that process is going to be flawed. So tell me, what would you guys do? How can you guys make sure that those risk assessments are being completed? What can you do as a manager to make sure that they're following, process and things like that?
I think you have to go around and monitor the documentation for a kickoff. You have to actually scrutinise, don't you? And you as an overall band 7 with the overview of your department, you're going to rely on your band 6s or whoever's the most senior person in that area to have the responsibility for actually monitoring of that, and to actually going around and doing it. Like, there is nothing wrong with going around and physically checking that care plans are up to date and these things are done. It's as simple as that, in my opinion, that, it takes somebody to actually go around and to physically examine documentation and not just look at what's been written, but to look at the patient. Wow, how is their feet and heels been? If they've got a pair of shoes and socks on that's still laced up, and do you know what? You wouldn't take it off and then put it all back on, would you? So there's kind of things that give it away.
Yeah. Agreed.
So,
I think it also, one of the biggest things that stands out for me as a manager is leading by example.
Absolutely. Yeah.
Because how can I expect I'll use the same term again, the band 5s, to be able to make sure that they're doing those things appropriately if my 6s and 7s aren't doing it?
Absolutely. Yeah.
So it's about leading by example. And it comes back to consistently reviewing it. And like you said, it is about sometimes physically going around a department and looking in a book. It's looking in the book to make sure that those things are being done. And it's so funny how things have developed over a period of time with risk assessment. So I can remember the very first patient, back in, what year is it? When did this start? 2020 COVID? Yeah. So back in 2020, I remember the very first patient that came into the department in January. And I was unfortunately the person that was on duty and in charge. And at that time, it was preparing for the unknown. We had no idea what extent this was going to happen. And at that time, the process was, if you were alerted that one patient, this one single patient was coming into the department that possibly had COVID because they'd recently returned from China, it was. And I had to put on 2 pairs of disposable scrubs. So the first layer and then a second layer. And then, obviously I put a full gown on. I had a FFP3. I had like a huge big hood, everything. And I was like walking like a Michelin man into this person that was probably horrified that I was walking in like this. And then when I'd walk out, I'd have to take that off, dispose of half of it, take off my first layer of disposable scrubs. I could go and do something else. And then I'd have to go back, put it all back on again to go back in. And then obviously I couldn't have done that with the number of like the level of patients and the volume of patients that were coming through. So that's when processes and policies developed and things like that, where it turned out, make sure you wear your uniform in, you wear a gown, you don and doff appropriately. And then at the end of your shift, you get changed, you have a shower, and then you leave in other clothes, which is dramatically different to that very first patient. But actually, the only way that those processes and policies were developed was because we were constantly risk assessing the situation. Is that a feasible and realistic action to be able to continue to do that kind of degree, or is there something that's more simplistic but just as effective that we can be doing to help prevent that passing on of infection? So it's been interesting to be able to reflect on those events as well. But that actually brings me to the end of tonight. So thank you for tonight.
Thank you.
Wow, that's been quite a tour, Jenna.
It has, hasn't it? Yeah.
Quite a tour. There's a lot of food for thought there, folks.
Yeah.
And you know, you can really see the difference, can't you? That Jenna's taken us through it's step by step there, that when you're just doing an individual risk assessment on a patient that you've been told to, because that's what you've got to do, you don't realize how much structure is behind that, and you don't realize how much help is behind that as well. Now absolutely, I see a comment, Jasmine, about being mind blown. Please do watch this back on catch up. It will be available later this week on catch up, so do feel free to replay it. The joy of doing lectures with Fen is you can go back and you can replay the bits that you didn't quite catch the first time. It's not like we've done it live and you can't ever see it again, and replay whatever you get stuck with. But risk management is a big topic. That's why trusts have risk managers, and honestly, Jenna's so right. A well-written risk can make the difference between the lives of the patients and the staff being grim and it being sorted out.
It's almost
So
like
they have to be well written.
It's almost like when I said it's the difference between life and death, I was like, is that a really dramatic statement to make? But that's the truth. That is actually the truth, because that's the joys of working in healthcare, that patients put their lives in our hands. So we have to be able to make sure that everything that we do is risk assessed. You know, and I don't think I fully understood. I've forgot. I just had a stroke now. Forgive me. But I
Please
don't.
We've got a staffing problem at your place, haven't we?
And we've got no beds, so don't worry.
So what's new?
Sounds familiar.
But I don't think I fully understood the risk process until I became a senior nurse, and the importance about that scrutiny, and how, honestly, I feel like as soon as I finished reviewing the risk register, the 3 months comes around and I've got to do it all over again.
I feel your pain on that one, Jenna. That's definitely a thing. Make darn sure the risks are all in date before you go to the next meeting.
Yeah,
I think knowledge is power, though, isn't it? You've certainly raised my awareness of this issue, and it's been a thoroughly enjoyable, and I feel I've gained a lot from this tonight. So thank you very much.
Oh, that's really nice to hear. It's really good. Thank you. Yeah. I hope you can take it back and put it into your own practice, essentially.
Yeah, absolutely. Yeah.
It will take a lot of thinking about, Jacqueline, because, you know, mostly we kind of rock up at work and we go and do our job. And we think that's what there is to it. I just have to rock up at work and do the job. And you don't realize how much thought has gone into how your job is being set up so that you can be successful.
Yeah, absolutely. Yeah. I'm retiring, Sue.
Need to go and have a sleep now. Thank you very much indeed. Now, our next dedicated MPhen lecture is on the 10th of February. And that will mark the first of a series of 3 where we're looking at how we manage difficult behaviour from patients. So we've got a series of 3 sessions. The first one will be managing cognitive impairments, so where patients are really, really difficult because of the level of their cognitive impairment. The second one will be managing patients who've got really, really difficult behaviour because of alcohol related problems, and the third one will be you won't be surprised to hear about drug related problems. So we're just going to, you think, hang on, we've got 2 hours on that? Yes, we have got 2 hours on it each time, because actually we need to just unpeel each of those and really give it some concentration, because it's all doable, but you have to just take some time out to really think about what's going on, why it's going on, and how you can improve it. So that'll be a series of 3 starting on the 10th of February. Next week is the first Thursday of the month. So that's the monthly FEN webinar, and I can't for the life of me remember what's scheduled for the first Thursday in February. So
wasn't it sudden death?
Well, done that.
That was AFEN. That was this week. This week and last week for the AFEN program.
Sorry,
I don't have the monthly webinar program to hand. Although I will advertise early and now the webinar on the first Thursday of March is Gary Jones, and he's going. Those of you who've never heard of Gary, he's considered the grandfather of emergency nursing. And he's going to come and talk to us about the history of emergency nursing. So I would very much encourage you to put that first Thursday of March in your diaries and come along and listen to Gary, because it'll be fascinating to listen to what it used to be like and how it moved from there to where we are now. But there we go. So that's what my advermercial for the evening. Okay. Good night, everybody, and thank you so much for coming.
Good night. Thank you.
Bye, Jack. Bye, Dan.